So good afternoon, guys. My name is Sunpil Hwang. I'm from North Alabama Medical Centers. This is a case about the metastatic melanoma presenting with repetitive intracranial hemorrhage. I'm gonna give you the brief information about the patients that we had. So this is 75-year-old male. He has past medical history of Parkinson's disease. He presented to the hospital 1 month prior due to intracerebral hemorrhage at the left parietal occipital junction. At the time, we thought that the patient had a repetitive fall from his Parkinson's, so it might be the intracranial hemorrhage from this fall. So the patients only went to the stroke workup and was discharged after that. However, this time the patient presented due to progressive decline in mental status. He did not have any fever, headache, no neck stiffness, or a history of trauma. Other review of systems were quite unremarkable too. On neurological examination, the patient was quite drowsy but easily arousable, and the patient was able to follow commands. He did not have any weakness on extremities. All cerebellar and cerebral examinations were also within normal range. So this is the initial lab result and imaging of this patient. Initial labs were quite unremarkable. The patient's CBC and BNP were fine. LFT did not indicate any hepatocellular diseases. If you see the initial imaging, I have pulled out the 2 CT imaging and 2 MRI imagings. If you see the CT imaging on the upper side first, the last one is from the last admission, which means the 1 month prior to this admission. You can see the enhancing hemorrhagic lesion at the left parietal occipital lesion. The size was around 13 to 15 milliliters. If you see the CT imaging on the right side, that's the imaging taken on this presentation. The size was around 15 to 16 milliliters. However, the location was exactly the same. There is some mild edema noted around the hemorrhage, but there is no any midline shift, no any other mass effect. If you see the brain MRI below, these 2 images both were taken from the current admission. The result of MRI was quite same, consistent with the CT report. Is just showing 1 centimeters of a left occipital lobe mass with associated with hemorrhage and unique enhancement. However, if you see the MRI imaging on the right side, there is no any hemorrhage noted on this image. However, I wanted to show you about the leptomeningeal enhancement. You can see some leptomeningeal enhances spreading inside of the brain like a web. This is not a regular findings we can have from the normal brain MRI. So from this imaging report, actually, there is a possibility of hemorrhagic metastasis. So the neurology and neurosurgery were both consulted, and they recommended metastatic workup for this patient. And the patient went to abdominal, pelvis, and chest CT, and this is the imaging result of the patient. If you see the chest CT, you can easily pick up the node or mass from the chest CT. This mass is around 2 centimeters, which was located at the left upper lobe. And if you see the abdominal CT on the right side, it shows some enhancing mass behind the left kidney. It was actually amenable for the biopsy, so the patient underwent for the biopsy of this area. And on the day 6, the pathology reported a metastatic melanoma with BRAF mutation. If you see the pathology slides, you can easily see the melanin pigmentation of this imaging. And also, if you see the cell more closely, it has over feature of malignancy like pleomorphism or nuclear membrane irregularities or prominent nuclei and mitotic activity. And the 2 images next to H&E stain is SOX10 and melanin A immunohistochemistry stain. Both are pretty significant, indicating this patient's having metastatic melanoma all over his body. So the radiation oncology initiated palliative whole brain CT, and also IV dexamethasone was started for the edema. After that, the patient was discharged to the rehabilitation center, and he was scheduled to follow up with the hematology oncology for the further immunotherapy and radiation therapy. This is quite interesting case considering the patient did not have any history of melanoma, but was found to have melanoma on his brain and also all over his body. And also this patient present with a repetitive intracranial hemorrhage at the same site for the melanoma. So there are 2 points that I wanted to emphasize from this case presentation. One is metastatic melanoma. As we already know, melanoma is pretty really frequent in this United States. Is ranked as the 5th most prevalent cancer, and it usually metastasizes to the brain very frequently, which can lead to intracranial hemorrhage. However, it can go to any other organ. So whenever the patient had the metastatic or has a history of melanoma, the physician should have a high level of suspicion when we follow up the patient. Other thing is the abnormal intracranial hemorrhage as depicted in this case. Usually intracranial hemorrhage typically associated with stroke or vascular abnormalities. However, if the pattern of bleeding is atypical, like in this case, the physician has to consider like secondary etiology of this bleeding, like in this case, a cancer. So these 2 points are the things that I wanted to point out, and this is the last of my presentation. Thank you very much.
All right. Any questions from the audience? So we have one question. Was the primary melanoma located?
No, this patient has no history of melanoma before.